Okay, good afternoon, everyone, and welcome to the Blood Transfusion Education Discussion Group. My name is Selma, and I'm here with my co-host Nella today. And this is the meeting number 49. So Tracey has over 25 years of experience as a BMS, and she has worked in both red cell reference laboratory in NHS BT, as well as hospital transfusion laboratories. From her experience in NHS Blood and Transplant and hospital environments, Tracey has developed a special interest in building stronger relationships between the two. So this led her to take up the role as a national lead for patient blood management, a post that she hopes will allow her to continue building collaborative relationships between NHS BT and the hospital transfusion professionals. Tracey also sits on the SHOT working group, and she contributes to the analysis of hemolytic transfusion reactions and has been involved in writing BSH transfusion guidelines. So in today's sessions, we will discuss the different difficulties in confirming a suspected transfusion reaction in patient, and we'll explore some of the laboratory tests that can support this.
Okay, thanks everyone. So as Salma mentioned, my name is Tracey Tomlinson, and I have worked in transfusion for a very long time. I feel a little bit old after that introduction, to be honest. But most of my career I've spent in laboratories, and I have developed an interest in transfusion reactions, especially through my work with SHOT. So the area that I am really interested in is hemolytic transfusion reactions, but as part of that work, obviously, there are other types of reactions. So we're going to look at all sorts of reactions during this presentation. So first of all, what is a transfusion reaction? So a transfusion reaction is a reaction that your body has to blood that's not compatible. So it's an adverse reaction, and it can range from mild symptoms like fever, hives, to really severe symptoms like renal failure and shock. So what are the signs and the symptoms of a transfusion reaction? So we can have fever, chills, tachycardia, hypertension, collapse, rigors, flushing, hemoglobinuria, urticaria, bone muscle, chest pain, abdominal pain, shortness of breath, nausea, and generally feeling unwell, and respiratory distress. So these are not all of them. These are just a few, you can see, but you can get all of these or some of them, and also you can get a different range, so different severities of those symptoms. So it might be mild pain, it might be very severe pain. Your patient might get very, very unwell, or just have that feeling of everything's not quite right. So there's lots of different types of reactions that can occur, and we define them as acute and delayed. So acute reactions are defined as occurring within the first 24 hours of transfusion in most cases. We do have acute hyperemolysis, which is the first 7 days post-transfusion, but majority of the acute reactions are 24 hours post-transfusion. And these can be divided into immune and non-immune type reactions. So your immune type reactions are your hemolytic reactions, which can be acute straight away, febrile reactions, allergic and anaphylactic, transfusion-related acute lung injury. And you can also get non-immune, like bacterial contamination, transfusion-associated circulatory overload, hypertension, and non-immune hemolysis. And then we have the delayed type reactions, which usually occur after 24 hours, and these are delayed transfusion reactions, graft versus host, post-transfusion purpura. So they're the type of reactions we could see. So how do we classify? Now, unfortunately, it's not always easy to classify a transfusion reaction. If we're giving our transfusion to our patient, it means they're unwell. We don't give transfusions to healthy people. We give them for a reason, and that's to treat symptoms of a condition. And if they're unwell, they probably already experienced some symptoms that may be the same as those that you see in a transfusion reaction and may mask those with transfusion reaction. They may also be getting treatments that could mask some of the symptoms, or could also produce symptoms that are the same as what you'd see in a transfusion reaction. So it can be very, very difficult. Also, all patients are equal, just like all people are equal. So you'll all know someone who, will be practically dying before they tell you that they feel unwell. and they come into work and you can see that they're really unwell, but they just carry on regardless. And we get patients like that, so they will carry on regardless, and they won't always speak up if they're feeling unwell because they think actually they are unwell and that's why they're there. And you get other people who, they stub their toe and suddenly they've got a broken foot and they need to go in a cast. So we get people at both ends of the spectrum and we get patients at both ends of the spectrum. So it's really, really difficult. Also, having a transfusion, it can make your patient quite nervous. So some of the things you see occurring just because they're nervous could also be symptoms that you could associate with a transfusion reaction. So you might get an increase in heart rate, you might feel a little bit clammy. A lot of people have needle phobia, so as part of a transfusion you're going to have a needle. So they're all things that could be considered part of the transfusion reaction, and we know this is a big problem. And I've given a link here to a paper that was reported in 2019 in which a hospital did a study, and they identified multiple patients who had transfusion reactions, but it was actually misdiagnosed as a vaso-occlusive crisis in a sickle cell patient. We also have patients who it's difficult to diagnose if they've got a hemorrhagic transfusion reaction or hyperemolysis. So it can be very, very difficult. Patients quite often are septic if they need a transfusion, and it's difficult to diagnose the difference between that and a patient who's getting a bacterial contamination from a unit. So we know there are problems. Within the shot reports as well, we've also seen, it's been reported multiple occasions that patients are having reactions that are not necessarily being diagnosed and misreported. And a classic example of that is hyperemolysis. So if you look in the shot reports, there's very few cases of hyperemolysis reported. However, if you talk to any hemoglobinopathy consultant, they will be able to give you multiple examples, probably from the last 6 months, of patients who have had hyperemolysis episodes. So we know there's a disconnect between what's reported and what's seen in clinical practice. So I'm just going to go on and just give a little bit of a further example of the problems we can see. So this table just shows the symptoms and what you would see in a vaso-occlusive crisis in a sickle cell patient, and also what you'd see in a hemorrhagic transfusion reaction. And excuse my little bit of a wobbly tick, but you can see the things you'll see are identical in the two scenarios. So in both of you will get hemolysis of red cells. Patients might report pain, fever, nausea and vomiting, hemoglobinuria. They might get a drop in their HB, an increase in bilirubin, and these are just some of the symptoms that you might see. So why is it important that we correctly diagnose a transfusion reaction? Well, the first thing is we need to make sure that we get the correct treatment for the patient. So if they're having a transfusion reaction, we want to make sure that we're correctly treating that, and also that if it is due to their underlying disease, or that we're correctly treating that. We don't want to treat them for a transfusion reaction if it's not that and it's something else. And equally, we don't want to ignore a transfusion reaction because we think the symptoms are due to their underlying condition. We need to be able to make sure we can manage future transfusions. So make sure that we know that what products to give them in future, whether they need any special requirements, whether they're going to need washed red cells, antigen negative red cells. We need to be able to manage the patient. As I said, transfusions themselves can make a patient quite nervous. It's quite an invasive procedure. If you've had one transfusion reaction, you're probably going to be a little bit nervous about having more. And we see quite often in the literature that patients have repeated transfusion reactions, especially the more febrile allergic type. So we want to make sure that we can manage our patient to calm them down, and also our clinical teams so that they can react appropriately as well. And finally, we need to make sure that we can report it correctly for our hemovigilance schemes, because our hemovigilance schemes and correctly reporting transfusion reactions can be really, really helpful for us to know, one, the extent of the problem, so we can manage them in the future, but also so we can make corrective actions to try and reduce the occurrence of transfusion reactions. And one historical way that we've managed to do that through hemovigilance was their use of leukodepletion to remove the risk of febrile reactions due to white cells. So we can see that quite clearly if you look back on old shot reports, that before leukodepletion there was a higher rate of febrile reactions, and after leukodepletion it drops. So we can use the hemovigilance to work out what's working, what's not working, and also what else we can do to try and prevent transfusion reactions from occurring, or to try and limit the impact of transfusion reactions on patients, because with a lot of these, early treatment can help to manage the patient as well. So if you're interested in adverse events to transfusion and transfusion reactions, I would definitely refer you to have a look at the shot reports. They're all available online, and they are all available on the website, in that you could go to individual chapters as well as go into the full report. So if you'd like to just look at, for example, TACO or TRALI or hemotransfusion reactions, you can just link straight to those pages. So I would definitely recommend, if you're interested, to have a look at those. So how should we investigate a transfusion reaction? Well, handily, there's some BTEDG guidelines that tell us what to do. So within those BTEDG guidelines, there's a lovely little flow diagram which will tell you the process to investigate transfusion reactions, and it also helps to define the type of transfusion reactions that your patient's having. So I'm not going to repeat what's in the guideline. It's there available for people to refer to, and it's definitely something that it might be handy that if you are in a situation where you suspect a transfusion reaction, just to pull it up and have a little look at that flow diagram and see if there's anything you can do to help you go through that investigation. So the first thing we need to do is inform our blood bank. So we should always inform the blood bank of a suspected transfusion reaction. There's a few reasons for that. One is to retrieve pre-transfusion samples. So pre-transfusion samples can be really, really vital to repeat that investigation. So a lot of the investigation looks at comparing the results pre-transfusion and post-transfusion. And in a lot of cases, we find that the pre-transfusion sample has already been discarded when the transfusion reaction is identified and reported, especially in those delayed cases, which might happen weeks or months after the initial transfusion. So the sooner we can let the blood bank know, the sooner they can retrieve that pre-transfusion sample and make it available for additional testing. They can also offer advice. So they can offer advice on what to do, where to look at, sources of information, and they can start the initial investigation. And often the initial investigation for a transfusion reaction will start with checking paperwork to make sure actually have we got the right patient, has the right unit gone to the right patient, and all the non-exciting bits, so not the laboratory testing bit, but the paperwork parts of it. So we can start looking at that if the blood bank. So the laboratory tests, really for the laboratory tests, what we're doing is looking for changes and patterns. So a laboratory test in itself doesn't diagnose a transfusion reaction. What we're looking for is changes between the pre-transfusion situation and the post-transfusion situation. So if the patient's got a fall in HB, for example, there could be multiple reasons for that. So if we look back at the patient's history and their HB was falling before the transfusion, there's probably an underlying reason unrelated to that particular red cell unit. We also want to look at patterns. So we can look at changes in some of the results. So a new antibody by itself might not be diagnostic of a transfusion reaction. It might be just that the patient's become sensitized. However, if you get a new antibody detected post-transfusion along with signs of hemolysis and the positive DAT, then it's more likely that the patient's having a reaction than if it's just a new antibody by itself. So we're really looking for those patterns. And those patterns can also give us some key tips for defining against different types of reaction. So within the hemolytic transfusion reactions, the patient's reticulocyte can be really, really useful for defining between hemolytic transfusion reaction and hyperhemolysis. So in hyperhemolysis, we see the retics start to bottom out, and that's what we're really looking at, whereas in the hemolytic transfusion reaction, the retics will start to increase. So those patterns are really, really important, and that's what we're really looking at in the laboratory tests. We're looking for changes in the serology results, changes in the chemistry results, changes in the hematology results, and patterns. Do our patterns of results match what we would expect for a transfusion reaction? We also have the NHS BT reference labs who can help with investigation of transfusion reactions. So really, the reference labs are just an extension of the hospital laboratory tests. They perform majority of the same tests that your hospital labs will be able to perform. However, they do have different techniques and technologies, and they might have more specialist testing. So they might have the ability to do testing that you can't do in-house just because you haven't got that technology or you haven't got those reagents, because sometimes the reagents that you need to do these advanced testing just aren't cost effective to have in a hospital laboratory, just by the sheer numbers that you'll be investigating. In a hospital transfusion laboratory, you might have one of these more complicated samples once or twice a year. So by referring them into one central reference laboratory where every hospital in the country refers in their 1 or 2 a year, we're then looking at, 1 or 2 a week, which means it's more cost effective to have these extra reagents or technologies available. And also expert advice. So there's people within NHSBT who are experts within the various areas that you're looking at, which can provide advice. And also there's the NHSBT consultants who are always there to help as well. So the reference laboratories available within NHSBT include the RCI lab, the HNI lab, platelet immunology labs, microbiology services, which look at both bacteriology and virology, and the International Blood Group Reference Laboratory. So I'm just going to look at each of these a little bit more in depthly about what they can do to help you investigate a transfusion reaction. So the red cell immunohematology lab, sorry, that's a bit of a mouthful, the RCI lab, which is why we call it RCI, is the lab that deals with red cells, as the name implies. So these really help to investigate reactions due to red cell antibodies or some of the IgA mediated reactions. So the thing that the RCI lab will have, which the hospital transfusion laboratory might not have, is access to a vast increased number of reagent panel cells and also some rare panel cells. So they can, it's more easy for them to identify the antibodies because they've got more reagents at their disposal. And they also have some different techniques they can use to help them. One of the key tests that's useful to help in diagnosis of a transfusion reaction is the DAT. And as I've mentioned before, by itself, a DAT, isn't always diagnostic because a lot of patients will have a positive DAT for other reasons. However, if you see a change in that DAT, that's what you're really looking for in a transfusion reaction, and that's probably what's more indicative of a transfusion reaction rather than something that's been going on already. The one thing that the RCI lab can do for the DAT, which a lot of transfusion blood banks can't do, is that they can do extended DAT testing. So in addition to testing for IgG and C3d, they can also test for IgM, IgA and C3c. I've already mentioned antibody ID, so they have a wider range of panel cells available. So it just makes them a little bit easier for them to identify antibodies because they've got more panel cells that they can set up, but they also have access to rarer panel cells. So panel cells for high incidence antigens and also panel cells for low incidence antigens that are not always available on your commercially available panels. And the other thing that's really key is elution studies. So within any textbook or in the guidelines for a transfusion reaction investigation, you will see the recommendation to do elution studies. So what elution studies does is it elutes off the antibody that's bound to the red cells in the patient's circulation and then looks at the antibody specificity of that. Now, this can be really, really key to identifying whether an antibody that's developed is causing a reaction. So is it binding to the transfused red cells or not? And this can often help you to identify which specific specificity it is that could be responsible for the reaction, because as most of you all know, patients don't always produce one antibody at a time in a nice order to help us with this type of diagnosis. They can have multiple antibodies present, and they can also have multiple antibodies that could be implicated. So elution studies can really help us to work out what antibodies are binding to those transfused cells. So what could be the cause. The H&I laboratory provides services related to solid organ, stem cell transplantation, platelet immunology, and HLA and HPA testing. So these are really involved in transfusion reactions for the white cell type mediated. So your more febrile type reactions, your granulocyte type reactions. So they can really help with that, and they can look for HLA antibodies and also platelet antibodies. Microbiology services are absolutely key. So they provide reference for monitoring of epidemiology to support the services of NHS BT, but also to look at what's coming through. So the microbiology services have been absolutely vital recently for lookbacks performed due to HIV and Hep C as part of the IBI investigations. They are also really important to looking at infections coming through about microbiology, so bacterial infections. The reason why it's so important to contact NHSBT if you suspect a transfusion reaction is that what they will do is they will look at the supply chain and see if there's any other components from that same donor that are in the supply chain, and then they can put in place recalls to try and prevent them from being transfused to other patients in the interim. So what we don't want is, if we know there's a possible bacteria contaminated unit out there, we don't want other possible units to remain in the supply chain and be transfused to that patient when we could have prevented it. So it really, really is important to try and let them look to stop that from happening. And the final lab that really, really helps is the International Blood Group Reference Lab. Now, on this slide, it looks like, they don't do as much as the other labs. They are really, really key. These are the experts for the experts. So these are the people that RCI refer the antibodies that they can't identify to. And they can do much more advanced antibody identification. They have access to a lot more specialized techniques, a lot of enzymes they can use, and also a lot of recombinant proteins that can help them to identify the more rare, wonderful and exciting antibodies that we don't see on a day-to-day basis, the ones that we see, once or twice a year. So they are really key for the more rare stuff. And they also do a lot of surveillance, so looking at what antibodies are clinically significant, and they produce a lovely document that's available on the Hospital and Sciences website that defines the clinical significance of red cell antibodies. So there's a lot of background work there as well. So what do we need to do for the investigation? So communication is absolutely key. We need to communicate with the clinicians, the patients, and the laboratories. So we need to make sure the clinicians are there, they identify the symptoms, they report the symptoms, and they consider whether it could be a transfusion reaction. And like I said before, some of these reactions can have really, really subtle symptoms that can be due to a transfusion reaction, but could equally be due to the patient's underlying condition. So they need that experience, that knowledge, and that empowerment to actually say, I'm not sure if this is right, we need to investigate it further, and maybe even stop the transfusion while that's going on. We need to talk to the patient, because the patient knows how they're feeling. No one knows better than the patient how they're feeling and whether they've started to feel more unwell during that transfusion. And we also need to talk to the laboratory. The laboratory might have information available that can help in that diagnosis, or they might be able to support those investigations going on. We then need to assess the type of reaction that we think it might be. So there's national guidelines available to help with that. There's always local policies and guidance within laboratories. And of course, as I've mentioned before, there's NHS BT consultants available who can always offer advice. Once we've narrowed it down to what type of reaction we think it is, will then help to guide us what type of investigations we need to do. So red cell mediated reactions, most of them can be investigated locally. So the pre and the post transfusion samples need to be tested, and the hematology and chemistry tests also need to be performed and reviewed. If referral to RCI is needed, because you need those more specialised techniques, they will be managed by the local transfusion department. So those requests need to go through the lab. They also perform the anaphylactic type investigations for IgA, suspected IgA deficiency. But for those reactions, it would really be the NHSBT consultant who would be able to give advice about what needs to be done and what needs to be done later on to protect the patient as well. Febrile reactions are referred to the H&I lab for testing for HLA antibodies. And again, that referral is managed by the transfusion laboratory. So it really is key to make sure the blood bank is aware of what's happening on. And then for bacterial contamination, NHSBT consultant advice is absolutely compulsory. And that's for those reasons that we mentioned before, that we need to make sure there's no other possibly implicated units out in the supply chain that could cause further problems to other patients. NHSBT will arrange for the pack to be returned for testing, and cultures will also need to be performed on the patient, and they're usually performed by the local microbiology laboratory. Other things that can complicate investigation of transfusion reactions in the laboratory, especially in the assays for red cell, is autoimmune hemolytic anemia. So patients with autoimmune hemolytic anemia will experience hemolysis, and that's usually how it's diagnosed. So they will have a drop in HB, they will have increased bilirubin, and they will experience red cell destruction, so they will have signs of that on their blood film as well. So usually this will be investigated by RCI, and they will use some of those more advanced techniques that I've spoken about. So they will do the extended DAT, they will use elution studies, they might have to use absorption studies to see if there's anything underlying. So for absorption studies, you absorb out the autoantibody to look if there's any alloantibodies underneath, and they might also perform genotyping to try and work out, what antibodies could the patient cause that could cause a reaction. Platelet refractoris is another one. Again, you will see the problems with platelets that you similar to what you see of red cells. The platelet count will fall. You'll see fragments in the blood film, and if you suspect that, they need to be investigated by an H&I department. So they will perform HLI typing, antibody testing, and if necessary, they may be able to help match for platelets, HLA match platelets, and the same with HPA. So they'll be able to type, do antibody testing, and if necessary, help match. The another thing that's really important when investigating transfusion reactions is reporting. So it's okay performing those laboratory tests and keeping the results, but actually, because we're looking for patterns, it might not be immediately obvious that the patient's had a transfusion reaction just from those results in isolation. So it's important that the potential or the fact that the patient has had a transfusion reaction is documented in the patient's record. It's also important to inform the clinical teams that this has happened, so that they can be on the watch in case the patient has to have any other transfusions, so that they can correctly diagnose any future transfusion reactions, but also so that they consider whether transfusion is the most appropriate treatment going forward, or if there's another alternative they could use. You need to inform the patient. Again, patient empowerment is hugely important with this, not only to let them know what's happened, but also to encourage them to let their healthcare professionals know if they experience any change in their symptoms, especially those symptoms that could be due to a transfusion reaction. And then once that's been done, you need to develop a care plan for that patient. So how are you going to manage them going forward? Especially if they are more anxious because they have had repeated transfusion reactions. You also need to consider whether your reaction is SABR reportable. So if it was due to an error, it will be SABR reportable, and also whether it's shot reportable. So shot reportable for hemovigilance. And those are really important because, like I said, we can use that data to help look for trends and also put corrective action in within the blood supply to try and prevent further reactions or to reduce the risk. And finally, we need to inform NHSBT if it's suspected to be bacterial or viral, so that we can do those look backs and also check if there's any other patients potentially at risk. So in conclusion, diagnosis of transfusion reactions is not easy. And laboratory tests can help this, but they aren't the be all or end all. And it involves multiple parties and collaboration of people working together to get to the answer. So thank you very much for that. That was a whistle-stop tour, I know, but has anyone got any questions?
Thank you, Tracy. That was amazing. Oh, I'm echoing. There's a couple of questions in the chat. Did you want me to read them?
I'm just opening the chat. So there's a few I can see about, wasn't this presentation is supposed to be about blood supply. So if you joined a little bit late, the person who was supposed to do the presentation about the blood supply unfortunately was not able to attend today So you have a backup presentation from myself. So apologies if you did come expecting a presentation about blood supply. It will be rescheduled. Is that correct, Selma?
Yes,
Yeah.
yes. Also, Mooney asked about regarding multiparous women. It's contraindicated. Sorry, the chat is jumping. It's contraindicated to collect platelet plasmapheresis from them to avoid TRALI. What about whole blood donation collection from such donors? Is it also preferred to be avoided?
So with the patients who have had multiple pregnancies, the risk is white cell antibodies, HLA antibodies. So the risk of that has reduced since we've introduced leukodepletion. So anything that goes through leukodepletion, there's a lower risk of that causing problems, because those white cells will be caught by the filter before they go through. Because leukodepletion, and there's such a low number of white cells within a red cell. So patients who have had multi-pregnancies can donate red cells, and they can donate platelets which are pooled, and again that reduces up the risk even more. So we do it, but what we would recommend if a patient has multiple reactions, we would recommend that they get HLA matched, which come from apheresis donors. So there's only one donation involved there. So they then screened out to make sure they haven't got the HLA type what the patient's got the antibody to.
And then she also asked, can additive solution SAGM cause transfusion reactions?
So we have had patients who have allergic reactions due to things other than antibodies, or things to do with the red cell component itself. So not the red cells, not the white cells, not the red cell antibodies, the white cell antibodies. So we can have patients who have transfusions to the plastic in the bag, to the preservatives in the additive solution. There's also been case reports of patients having reactions to other things within the unit as well. There's one, I don't know if I believe it or not, but it was reported of a patient who had a peanut allergy, who reacted to something in it. So there are lots of things. We definitely have patients who can have reactions to things like the preservatives. We had one actually last year who was having reactions to the preservative, and we were having to provide washed blood cells for that patient. So yeah, it is absolutely true. These are very, very rare though, thankfully. So they don't happen very often. They can be quite difficult to diagnose. Usually it's by ruling out other causes of the reaction, and then looking at what's available. So there are other additives available. So most adult red cells are in SAGM, but we have CPD for babies. So you can try other additives to see if that's helpful. And also we can wash red cells and platelets to try and remove any additives if that's a concern.
Do you refer red cells or platelet packs for micro for culture? If so, when? We are currently reviewing our policy as most packs are insufficient for culture. Thanks.
So you'll be surprised what you can get out of a pack for culture. So yeah, if you suspect a microbiology, bacterial infection or microbiology type infection in either a red cell pack or a platelet pack, definitely contact NHS and they will arrange for the unit to be returned. So you want to contact them as soon as you can, because obviously once that unit's been laying around in a ward or a transfusion lab, there's a risk of environmental contamination. And what they often will be able to do is get a sample from, for example, the pigtail from the unit, which doesn't get transfused to the patient, or from the inside of the pack as well. So you'll be surprised what they can do with a little bit of remaining something in the bag. But NHSBT will always send you out a container to send it back in, and it's sent back by the NHSBT drivers.
Mike's comment made me laugh. Peanut allergy. Jokingly, have you considered putting this product by contain nuts on blood bags?
Honestly, no. I must admit, like I said at the beginning, I do have doubts about some of things that are reported. Just in general, we've all seen things that have been sensationalized. Another example is the HGN and Henry VIII report that went round a few times, and then there's a blood group diet as well. So yeah, I think we need to be careful when we're looking at any reports to make sure that the evidence is there and what the imputability was when it was reported. But no, I haven't considered putting this product may contain nuts on a blood bag.
Michaela, would you like to come in? Just unmute yourself.
Apologies, I put my hand up in error there, Selma. Sorry.
Okay, thanks. No worries. There's a question, is there a specific length of time the blood samples are kept that are tested when transfusion reaction occurs?
So most transfusion laboratories will have a period of time that they keep their samples for. And also the IBMS produces guidelines on how long samples should be kept post-testing. So most samples are kept at least 7 days. In some places they will freeze down plasma. Not every lab does that. Obviously there is that balance between having storage space for multiple samples and the need to go back to them. So it's always difficult, but most places will keep them for a minimum of 7 days, so that you can go back in the event. And that's why it's so important that if you suspect a reaction, to let the lab know as soon as you can, even if it's not confirmed. They might not end up having to do any tests because it might be for a different reason, but if they're pre-warned, they can get that sample and put it aside before it gets discarded. I must admit, I've been involved in my many years working in transfusion. There's multiple cases where we've done that. Oh, if only we knew sooner, we could have got that sample out and put it aside. So yeah, so 7 days is what most people will keep the sample for, but it does depend on storage space.
What are the management criteria for patients with platelet refractoriness who are suffering from platelet function defects such as Glanzmann thrombocythemia? Sorry, thrombocythemia.
Unfortunately, I am not an expert in how you treat those patients. So I'm not able to answer that question. What I can do is see if I can find an expert and come back with the answer.
How does NHSBT ensure the accuracy and reliability of the test, particularly when differentiating between immune-mediated and non-immune reactions?
So like I mentioned, the difficulty is that the tests are not diagnoses by themselves. What we're looking for trends, and we're looking for changes. NHSBT, like every ISO accredited laboratory, will have measurement of uncertainty for their tests. They'll have controls. They'll be required to do lots of QCs to make sure their tests are reliable, and they will have quality systems in place to manage that if they're not. So all the tests will have things in place to make sure they're accurate, and that's for all the different laboratories as well, and that's true for any laboratory that's ISO accredited, whether it's NHSBT or a hospital. And this is why it's so difficult. The reason it's so difficult to differentiate is because of the different things that could be causing those symptoms and those test results. So you really need to look at that trend and changes, rather than just actually an absolute figure. So a HB of 60 isn't diagnostic unless it's dropped. If the patient's HB is always around that value, then it's not going to make a difference, or it's not going to be the reason for the hemolysis. Okay.
Yeah, that's brilliant. Thank you very much.
All right. Thank you, everyone. Thank you for your time.